Every day, healthcare providers are tasked with maintaining life through years of study and scientific practice. But starting with its creation in the 70s, bioethics has emerged as one of the most important parts of a physician's craft, making the scientific world we thought we understood a home for the study of not science, but rather humanity. Bioethics is a complex subject that analyzes medicine's toughest ethical questions, and a healthcare provider's right to autonomy is a representation of how we as a society value teamwork versus individuality. So, without further ado, is a healthcare provider first a white coat on a person or a person in a white coat? In the world of bioethics, there are providers and there are patients, and how their autonomy is balanced against each other is an ongoing debate that entangles people's lives and their health. The precedent is currently set that patients have more, if not supreme, autonomy over their provider. They are entitled to full control over their medical care, which seems ethical, right? But in doing so, are we not also discrediting the individualism of that provider? A white coat on a person is still a person. They're an individual with autonomous rights who happens to practice medicine. A person in a white coat is an agent of medicine. Their actions represent the practice of medicine as a whole and are not at liberty to practice their career as individuals. This talk will go over the balance between provider and patient autonomy and provide examples that challenge the precedent by proving in some cases a provider has more autonomy than their patient. Patient and provider autonomy are two complex issues that constantly vie for dominance in the world of medicine. While patient autonomy deals in the negative right to refuse help or to be left alone, provider autonomy deals in the positive right to be helped. There are 4 rules to positive autonomy. How important is it that the help be provided? How well are others situated to help? Does the person have a job that comes with job-specific duties to help? And would helping the person violate any other moral duties? The 4th rule is the largest source of complication when it comes to medicine. Take a scenario where a pharmacist refuses to provide a woman with the birth control she's been prescribed out of religious objection. From a feminist point of view, his actions seem ridiculous and the answer seems simple. However, when the question is put into terms of forcing a person to do something that goes against their core beliefs and identity, asking him to give her birth control seems wrong. So the question must be asked, does a medical professional have a right to claim conscientious objection to certain aspects of their work? This would make them autonomous individuals more so than an agent of medicine. As of right now, the precedent is set that a medical professional can refuse to provide treatment to a patient on moral grounds so long as they still provide access to a separate option for the patient, like transferring a prescription. However, many clinicians with moral objections to giving treatment also have an objection to aiding in its completion. While technically the pharmacist can refuse to give a woman birth control on moral grounds, his refusal to transfer her prescription is a massive ethical violation. So it would seem that providers have more autonomy as individuals with morals and personal objections to consider. But as a society, should we agree that the refusal to provide sound treatment to a patient is okay, especially when medicine like birth control is vital to someone? Medicine is a balance between doctor and patient, and both autonomies must exist together even if they do not exist equally. The question of provider autonomy is also a question of what is a medical professional. One can address the rights of patients as a subdivision of ethics as much as one wants, but bioethics cannot exist until we start uncovering what it means to wear a white coat, and what power does that coat hold. Bioethics is so much more complicated than a trolley problem posed in a college ethics class, because it doesn't deal in hypotheticals. As much as you can learn from those problems, bioethics attempts to find answers to questions that will come to fruition. Provider autonomy is not only rooted in moral objection, but in intellectual objection as well. A doctor could simply claim, when it comes to the treatment of a patient, they know and understand better, so they should have more say over the course of a patient's treatment. It seems like a cruel thing to subject a patient to treatment because the doctor simply knows better, but there should be a consideration for context. Anorexia nervosa patients suffer from a massive preoccupation with food and weight that often results in their starvation. To treat this psychological disorder, patients are not only given therapy, but also meal plans that help them gain weight. This course of treatment is met with resistance and refusal, but in doing so, the patient is risking death from starvation. Many laws of provider and patient autonomy suggest force feeding is a violation of morals until the patient is deemed incompetent and feeding them is in their best interests. So, can anorexia patients be described as incompetent in order to save their lives? The Iowa Gambling Task measures a person's ability to weigh short-term and long-term consequences in terms of reward and loss. Anorexia patients were found to do significantly poorer on this test than did the matched controls, indicating the poor decision of anorexia patients. There is also the argument that because their perception of food and weight arose pathologically, those values are evidence for incompetence. However, it seems terribly paternalistic to decide which values are so extreme they're only pathological. Bioethicists are also forced to consider if a provider can override patient autonomy, even if they're not incompetent. In cases like anorexia, death is on the line, and in most cases, a patient's choice to continue starvation does not mean they're making an active choice to die. If a patient does not intend to die and would be thankful to have received treatment after the fact, is that not probable reason to force treatment on a patient? Anorexia is an extremely reversible disease. Even in the most seemingly futile of cases, a patient is always savable. When a patient is hospitalized and force-fed over and over and over again, doctors may only see futility in treatment and that it is best just not to let the patient suffer. This is simply not true because at no point are anorexia patients terminal. It is argued that autonomy is upholding for the principle dying with your rights on, but as a society, we agree life is not to be thrown away when remission is in clear sight. Patient autonomy is thought to remain supreme, and the obligation of the provider is to the will of their patient. However, this research describes a stipulation to patient autonomy where in every circumstance the provider knows best and can act against the will of the patient that will leave them better off emotionally and physically. In standard situations, patient autonomy takes clear precedent, but the evidence discussed makes a strong case for the dominance of provider autonomy in the treatment of anorexia. This issue is unique because there is no cultural or scientific objection to feeding a patient against their will in the cases of anorexia. Especially when saving someone's life is in sight, what justification is there for throwing that life away? Especially because no parties intend death, the only claim against complete provider autonomy is upholding dying with your rights on to protect dignity. Quite honestly, I don't believe dying unintentionally of starvation while your doctors and family watch has any dignity in it. Bioethicists who seek to uphold a precedent for the sake of that precedent are close-minded. Is theory not worth sacrificing for the patients you sought out to save? As much as we'd like it to be, medicine is not clear-cut. Every situation cannot be approached the same because, for better or for worse, medicine is much a study in humanity as it is a study in science. Walk up to a firefighter and tell them to let the suicidal patient they're trying to get off the roof to let them die with their rights on. Respect for life is not a disregard for dignity. Medicine should be about upholding adaptability, which means saving the anorexic patient in front of you at the cost of their autonomy. We also must consider public health in the wake of a provider-patient battle. The COVID-19 pandemic of this past year should open our eyes to that now more than ever. HIV is also a devastating epidemic that has been ravaging the world for about 50 years. There is no cure currently available, but doctors have developed the theory of opt-out testing to help catch HIV early and better treat it and prevent spread. Opt-out testing standardizes the performance of an HIV test every time a person between the ages of 13 and 65 comes in. Unless a patient refuses to be tested, they can count on a test right in with the checking of their blood pressure. However, there are many challenges posed to this theory, such as clinical setting, prevalence, and geographic location. These challenges are addressed through the perspective of a healthcare provider from all different clinical settings. This research focused on the opinions of healthcare providers in Kenya and South Africa, which have high rates of HIV and a limited clinical setting. Two findings emerged concurrent with healthcare provider attitudes and system deficiency. System deficiency was not surprising as there was a lack of time, resources, and proper training within the clinics. However, healthcare provider attitudes became more complicated because it revolves around the HIV stigma in Kenyan and South African culture. In cases where healthcare providers held stigma, opt-out testing seemed like a superfluous idea to them because they had certain pictures in their minds of what an HIV patient looked like. As a sexually transmitted disease, many held the strong belief that a little old lady or a married couple had no reason to be tested. Some healthcare providers also said even if tests were administered, they felt uncomfortable disclosing a positive test result. This was ironic considering they were accustomed to giving bad news along the lines of dead loved ones in an emergency room. Stigma also comes from the patients as well. One nurse expressed that she refused to give tests to a child for fear that implying that child had HIV by simply testing them would result in a lawsuit from the parents. Due to the taboo of HIV, healthcare providers feared that opt-out testing would offend or make patients uncomfortable and result in them not going back to the clinic at all for other medical needs, making national health worse off than it started. Opt-out HIV testing is a matter of bioethics because cultural attitudes are blocking the pathway to life-saving science, and how healthcare providers move forward is determined by the ethical laws of provider autonomy. Stigma and a lack of information leads patients to refuse testing, which not only puts their life at risk, but everyone they have intercourse with and potential children they may have. Traditional ethics claims provider responsibility extends to protect the wishes of the patient. But in situations like these, there are countless other parties at risk. Does the anonymity of the parties make them less of a consideration for that provider? Healthcare providers have attested to giving harsh ultimatums that it's either get tested or die. There is a strong desire to disregard ethics for public good via coercion, but healthcare providers still acknowledge that chips away at the already thin trust a patient has in their doctor. The ethics of provider autonomy has yet to draw the line when a doctor has done enough for their patient. What care a patient is entitled to outside the black and white of medicine. It is no secret that most healthcare providers have little to no education in dealing with the mental consequences of receiving positive HIV test results, which is a very traumatic experience for most patients. How a provider manipulates their craft to work around restrictive social stigmas will influence the course of one of the most deadly epidemics in the world. Medical futility is the third stipulation to supreme patient autonomy. Does patient autonomy hold more importance when the medicine they desire has no beneficence? ECMO is a machine designed to give the heart and lungs a break when a patient is suffering from a reversible heart or respiratory condition. The machine has incredible capabilities to preserve the most vital functions of the human body, but it only exists as a short-term solution. Those with heart and lung conditions are extremely susceptible to other conditions that will cause death. While the condition they are being treated for is reversible, while on ECMO, a patient will develop irreversible conditions that cause death once ECMO is removed. Despite ECMO being a short-term treatment for one part of the body, it is becoming used for long-term life support, and families and even doctors are scared to take a patient off of ECMO due to emotional attachment or legal ramifications. This seemingly logical argument is that pursuing treatment is futile and the patient should be taken off treatment. However, the definition of futility is quite blurry. At what point is the patient not receiving any benefit is not agreed upon. Since the purpose of ECMO is not to support the entire body, asking a doctor to continue treatment is a positive right, which leads to the idea that a doctor has more autonomy and can insist on conscientious objection. Weak paternalists argue that autonomy is about dignity and not the best scientific outcome. If that is the case, why does that not apply to protecting the dignity of the provider? Keeping a patient on ECMO can cause serious mental distress in a healthcare provider, especially for the nurses that are tasked with mitigating conflict and breaking the barrier between doctor and family. If autonomy is about dignity, we should not only look to preserve the dignity of the patient takes in dying, but the dignity a doctor takes in living. Now more than ever, we see the value of protecting our frontline workers and their mental health, because not everyone can be saved, but we can help the people that want to keep trying. Futility is a common debate in bioethics, and it's influenced by an alternating definition of death. However, what defines futility is not at play right now. It's the autonomy of the provider when that futility becomes present. There is no element of medical correctness here because the facts are set in stone. A provider is simply refusing to continue treatment out of conscientious objection. It exemplifies that a provider is a person too, and protecting the mind and rights to autonomy also protects the life they will save down the line. The conflict surrounding the withdrawal of ECMO and the rights of the provider are cut in favor of the provider. Even the strongest stipulations to patient autonomy still hold it in high regard, giving the provider only equal opportunity. However, withdrawing ECMO lies strongly within the decision of the provider. ECMO is used for short-term treatment of a specific part of the body. It is not meant to be a form of life support. Using it as such violates the way in which medicine should be practiced and justifies conscientious objection. There is also research into the effects of keeping a person on ECMO can have on the mental health of the provider. They become doubtful in their abilities and feel a sense of failure. Healthcare workers are our front line, and now more than ever, we see the value in protecting their mental health. A provider is a person too and has the same right to dignity as their patient. We cannot ignore the tragedies the families face when a loved one dies, but they only exist now. Healthcare workers will serve hundreds of people for years to come and are pivotal members of our society. As a society, we cannot continue to invalidate the autonomy of the ones who work tirelessly for the benefit of others, when the other is only demanding a positive right. The dominance of patient autonomy will always reign, but when positive rights are at play, a provider is entitled to their sense of self. We started with the question about what a medical provider was essentially, an individual or a representation of a bigger mission. The precedent set about the relationship between provider and patient autonomy seemingly proves that they are agents of medicine. However, research showed 3 stipulations in which a provider had more say in treatment than their patient, and therefore proving a provider is also an individual. Now, some of you may not care about the autonomy of a provider, especially because many of you are the patient. But this question is a small representation of the big picture, which questions how we value individualism versus teamwork. I found passion in bioethics because it was a new door of information on the way to my dream career. But I hope for you, from this presentation, you take away not only an interesting fact, but a better understanding of medicine as a humanity rather than a science. That the relationship between doctor and patient is more complex than we ever thought, and there really is no answer to the question I posed at the beginning. We just have to go forth, continuing to analyze context and think about what we want to value as a society.